I'm an acute medic, and that's my sort of clinical background. I was also a GP. As a result of that mix of community and hospitals, I've always seen all of healthcare really been about the collaboration between different interfaces. They're trying to break down the walls between silos and try and standardize as much as we do and the communication methods we employ to ensure we drop the ball less. And that patients with the most sickness are prioritized, but patients with lesser sickness are known about, so that we don't have the recurrent error cycle that we seem to go through when patients transfer from one care environment to another. Over time, we've had a lot of changes within sepsis. So we started with, very well-meaning documents like News 1, the Ombudsman's document, the Sequin, that we've all talked about, the Just Say Sepsis Awareness Report by NCPOD, and then more recently and more latterly, the implementation guidance from NHS England that's really brought together all of that into one very short piece of work that we are constructing our future Sequin around and potentially our future guidance regarding the care of infection and sepsis. News 2 was released in December, which brought some welcome changes. And then for this year, we are going to build upon that to really bring home the importance of marrying sepsis, infection, antimicrobial resistance around a framework within all-cause deterioration, so that we don't just ignore everyone with badness from other conditions and only focus on the one, but take in the majority and take in a standardized way of coping with all cases. Over the same time period, we've seen multiple different languages for how you describe sepsis, or definitions, starting from SIRS years ago, and then NICE guidance, then Quick SOFA, and then hopefully us moving towards a single way of operationalizing sepsis, infection, and deterioration under the heading of news, and a value of 5. So if you separate sepsis from deterioration, you basically cause harm, because you can't tell when someone comes in what is wrong with them. And the further you go down a didactic, blinkered pathway, the more patients you lose along the way. And if you tolerate the national variation that pre-existed this point in time, where we had multiple different scoring systems used in different places, so the national survey showed a 25%, 25%, 25%, and 25% split of what sepsis definition was operationalized across the whole of England, we risk really dropping the ball. And it led to our clinicians and our commissioners and managers actually, with hands in the air saying, what do we mean by sepsis? What does it really mean for patients? What does it really mean for healthcare professionals? And NCPOD summed it up quite well, in the sense of, if we don't have a joined-up language and a joined-up system, more patients with sepsis and potentially all-cause deterioration are going to die. So the question is where we went from there. So the thing I really love about the sepsis guidance implementation advice produced last year was how much it depended upon this concept of clinical judgment, the thing that we instill in all our clinicians that separates them from robots, that identifies their experience, the gut feel of our clinicians within all of this that's so critical within sepsis. For years and years and years, we've struggled with very complex guidance around what sepsis is. And what it comes down to time and time again is whether an experienced clinician is worried about a patient as being almost our gold standard test. And what this guidance has done is reinforce that. So News 5 becomes that line in the sand to say an urgent review is required. The concept that suspicion of infection should trigger people to think, could this be sepsis? And then a look for those concerning features that sort the wheat from the chaff. The terminology is really important. This isn't about sepsis. This is about the concept of suspected sepsis, because you can't prove sepsis, really. There is no gold standard test. We suspect it, then we treat it. And if we don't treat the suspicion, we are too late, because we can't wait for the confirmatory tests to come back, if they ever come back. So it's good that we are aligning with what Einstein, I think, firmly believed, that actually the human condition and our experience and our judgment is really key to our delivery of the best outcomes within this and a whole host of clinical conditions. Because there's a common pathway. We start with our person And then, unfortunately, at some point, our endpoint is death. And in between, there is a change of physiology that it maps to this concept of deterioration. So it's not the sepsis that kills you, it's the deterioration within your infection or other cause of deterioration that leads to your eventual organ failure and death. And what News 5 approximates to is organ failure, organ dysfunction. And it's probably the best barometer within early warning systems that are ready available across all interfaces of care for that. We have an opportunity, and this is where it gets really exciting, to actually do what has never been done before, certainly not in England and probably not across the world. Have a combined language for defining sepsis and deterioration that's housed around some pretty good evidence. The use of clinical judgment within it, and the use of News 2 to really embed a single way of thinking about things. For those not familiar with the changes in News 2, I'll be going through it in the sepsis talk later on today in detail, but what it aspires to and what the change is that essentially there is a chronic hypoxia subchart, so patients with advanced lung disease frequently over-triggered within using News generally in healthcare environments. And what it meant was that we developed a bit of alarm fatigue against those patients in some ways. And what News 2 does is it tries to overcome that by saying, actually, what is your baseline and what should be the revised trigger based on that? So it's really sensible, particularly in respiratory wards. The second really welcome change is the addition of new confusion. So instead of alert, voice, pain, unresponsive in the levels of consciousness section, you also have confusion. So we can pick up delirium, particularly in elderly patients or young patients. Another great signifier of bad outcomes. So this gives us the opportunity to think about a combined pathway. How do we combine deterioration and sepsis together within a framework of colours, but to denote a degree of urgency based on their mortality risk or the risk of needing intensive care admission? With the key determinant at the end of the day, clinical judgment applied to that. So the urgency is about the urgency of getting that clinical judgment. When we look at causes of harm, and Liam Donaldson did a great study in 2010 looking at this, what we find is that it's the mismanagement of deterioration time and time again that comes out number one, and usually communication within that as far as an RCA side of things. So it's not rocket science. Let's get deterioration right, and let's get communication within deterioration right, and we will save lives. The slope of deterioration is quite a grey area. We have a fixed point of time when it happens over, and then we have a degree of badness that happens that precedes a cardiac event, a cardiac arrest, or a death. And what News we hope will bring in is objectifying and standardizing that detection process of when a patient slips off that baseline through a validated scoring system that eventually leads to a review through, again, standardized communication systems across the healthcare interface, an intervention, and then an escalation to prevent that de-escalation and further deterioration in the physiological score and risk of death. And the hypothesis is really simple. Can a standardized language and pathway for sickness improve outcomes? And don't wait till you get to hospital to do one. So Celia was right. There isn't validation within general practice at present for this, but it just makes common sense. You know, it's a bit like a patient with cellulitis and not putting a line on their leg to where the redness extends to, and then sending them somewhere and saying, right, well, I think it was about mid-calf, and the patient will tell you this, but there's no red line to tell you exactly where it is. And this is what News allows us to do. It gives us a line in the sand to know whether someone's getting better or worse. It guides the urgency for the ambulance. It guides the urgency for the medical take. On an average Monday, I've got 25 medical patients waiting to come in from the community or by ambulance. Of those 25 patients, who do I see first? Who does the ambulance pick up first when we've only got 34 across the whole region that are on the road at any one time? It's a game to do with using your resource and using our intelligence collectively to prioritize the most sick and get them in the right location. And that's really important because we have a number of places to see sick patients, be it on the AMU in a clinic, in a waiting room, frequently in a corridor, sometimes in resus, sometimes the back of an ambulance. And without some sort of grading system, we don't know who we should be targeting. So it's a push and pull. It's about hospitals saying to GPs, this is the news on discharge. This is what their baseline is. Consider that when you're trying to work out whether someone's deteriorated. And for GPs trying to get patients in, or from care homes, or ambulances. This is the score at the moment. This is their risk as we perceive it at the moment. And because you're using the same scoring system, you'll understand that risk and you can prioritize accordingly. And, this has led for us to developing a triage protocol because, what you don't want to be doing is having to intubate patients and perform CPR on patients in waiting room areas. Patients should be moved to the right location first time, where possible. And we're starting to get GP referrals now with news, and it's amazing. It's transformative to the healthcare system because we know who the most sick is and who should be prioritized. From a regional perspective, the theory goes you start local, then you go to the region, and can we do this across our 5 million population? So it only took 4 of us to begin the process. An ambulance paramedic, who was amazing, a commissioner, who was incredibly innovative in his thinking, a GP, and then a hospitalist. And then the idea was, how can we improve our outcomes from deterioration and sepsis? So the theory was implement news everywhere, care homes, GP settings, ambulance, and across all the interfaces of care they're in. Come up with a scoring system within care homes, so the news chart in care homes, and an escalation based around very hospital-centric kind of communication templates like SBAR. An ambulance that had an auto-calculating EPR that utilized that to really convey the message. We got time for a film. Is this going to work if I press next? Is there any sound? It's just the BBC music. I could sing it if you want, but...
A major change in the way infections like sepsis are diagnosed. A scoring system developed by medics in Portsmouth and already used in some hospitals is now being introduced into GP surgeries. Sepsis is when the body tries to fight its own infection. 44,000 people die in the UK every year as a result of it. Symptoms include extreme pain and tiredness, shivering and a fever. Without quick treatment, it can lead to multiple organ failure and even death. Edward Salt has more.
I struggled to even get out of bed. I could not walk across a room without having to hold on to something.
Claire Moss, who's a nurse from Winchester, thought she just had a sore throat. But it was a sore throat that never went away and a sore throat that turned into sepsis.
When I was actually really, really poorly, when I was at home, I just didn't feel as though I could live anymore.
And it's cases like Claire's that doctors want to prevent. This is the scoring system GPs will adopt and is already being used in hospitals. A score of 7, for example, would mean your blood pressure is low, your oxygen saturation in your blood is low, and you have a high temperature. It would not only indicate that you need to be admitted to hospital, but would help your GP, the ambulance service, and the hospital to decide the urgency and level of care that you need. This will reduce the avoidable deaths caused by sepsis.
If you've got a high score, then the chance of something going seriously wrong and the deterioration happening over a rapid period of time means that earlier action needs to be done. Is this person likely to need hospital care in the next hour, 2 hours, in the next 24 hours? And therefore, we reduce the avoidable deaths with sepsis.
And that score will help people like Dr. Matthew Inada-Kim.
That was a PCT machine. This is really embarrassing, isn't it? The BBC picked this story up, which I thought was really interesting. They kind of thought this was really sensible. They'd had lots of bad sepsis cases that they've had to really lambast hospitals or primary care services about picking up sepsis earlier. But they saw this as a real good news story, I suppose, of how we could actually improve things. We also covered a little bit about procalcitonin near-patient testing within the same story, more of which later on in the afternoon. But, yeah, exciting stuff. And when you have a region that's fully committed, and my own region is almost there, but not quite as good as this one, West of England, AHSN, and then you compare their mortality from emergency admissions with infection when they've implemented news everywhere across their whole healthcare system compared to the national average. So green is the national, blue is what West of England have achieved. You find that actually it makes a terrific difference. And they are pretty much the only region in the country who are bucking that mortality trend. So what is the secret sauce and what is it that they have done that's different to everyone else? And I mean, it's full of terrific individuals, that particular region. But when you look at it, what you find is they've standardized all their acutes to news. They use a news EPR tool. They have an ED safety checklist built around news. They have these regional sepsis masterclasses that are brilliant. And they've implemented news across the community. So it's not a massive degree of extra work. It's kind of common sense, and it's kind of where the direction of travel is heading anyway. But it's great that there's some early evidence that it's making a big difference. Wales and Scotland have found the same thing in both of their respective populations, and it's not by fluke. This is about standardization of communication and protocols and pathways, whilst also retaining a degree of clinical judgment within it to allow our clinicians the flexibility to use their experience with. So the upshot of that is that by endeavoring to combine real-world pragmatism and frontline experience with evidence, engaging the system to find out what people are doing, and trying to achieve some quick wins like the data from West of England, AHSN, and through some collaboration, compromise, and consensus, we can actually get towards guidance, endorsement, possible future mandate, and regulation, all housed around these concepts of improvement and measurement that really bind us all together. And it's been a bit of a domino effect in that respect, because once you start to consider what the one service that really links all of us together are doing and the problems they face, and, speaking to ambulance trusts and saying, so how many different protocols do you have to work with in your region? And they'll come back with 9 for adults, 16 for kids, and 3 for pregnant people. And you start thinking, this is crazy. Why don't we just use one scoring system wherever possible? And so obviously the ambulance services around England were the first to really fully support this notion. But then the domino picks up steam because it's just common sense. This is about safety in patients and actually thinking about what will work for them. And this sort of translation, and this is what I think Seelering and Clark's done some terrific work with, is really thinking about the whole picture. Thinking about what clinicians on the shop floors are thinking, what commissioners are facing, and trying to standardize that language and trying to bring home and trying to get the NHS to the best it possibly can be.